It's going to be hard to figure out some type of like broad-based, consistent, monolithic payment model. It's really going to have to be priced and contract on a case-by-case basis, looking at the data, interrogating the data. That's where the next frontier is. We'll see how quickly we move, but that's where there's a lot of opportunity.
Welcome to the Healthcare Grind, where we cut through the noise in the healthcare industry to bring you the latest trends, innovations, and insider insights. I'm Jess Hearthcock, and I'm joined by my co-host, Lon Hecht, as we embark on a journey to connect early-stage healthcare companies, payer executives, and investors with the knowledge and perspectives that matter most. Get ready to grind in the fast-paced realm of healthcare innovation. And for more advanced content, go to healthcaregrind.com.
Hi, everyone. Welcome to another episode of the Healthcare Grind. My name is Lon Hecht, and I'm joined by my co-host, Jessica Hearthcock. We have another great guest for you today. We're joined by Frank Cheung. Frank is the co-founder and CEO of Accorded. He is also a health actuary. So really excited to have Frank on the podcast today. Frank, can you tell us a little bit about yourself?
Yeah, so as you mentioned, Lon, thank you for having me. CEO, co-founder of a company called Accorded. We're an actuarial intelligence company. My background prior to founding Accorded was that I was a health actuary for 15 years, working with health plans like Blue Shield of California, as well as helping providers and hospital systems around value-based care strategy.
Great. Well, thank you so much for joining us. We're really excited to have you on. So it's funny. Jess and I have been in sales for a long time, right? And every company I ever go to work for, when I get there, they always tell me, we have all these deals that are on the 1 yard line. We're about to punch it in. It's perfect. Then I get there. Takes me about a couple of hours or a day, and I realize that they're on their own 1 yard line. They're nowhere near getting in the end zone. They're not even in the other end of the field, right? And that's because there are so many things that early stage companies don't really understand. And one of them is medical economics and the importance and where they come into the process. So today I'd love to talk a little bit about that. If you could give us maybe a high level, what is medical economics? What is the group? When do they typically come in? Those kind of things that an early stage founder should be thinking about. That'd be really helpful.
Yeah, so the medical economics or the actuarial team sits within a health plan or health insurance organization. And you can think of them as the financial diligence gatekeepers to all things kind of financial related within the organization. They don't just work with business development teams and partnership teams to help drive economic and cost of care diligence. They work across the entire departmental operating flow of a health insurance company, supporting almost every single business line that touch a part of finance and economics. And so when it comes to these partnerships, very much part of the process of, making a sale is not only convincing kind of the clinical stakeholders, but also being able to patch that economic financial diligence around, well, if we do take on your product or solution or we do partner, is this going to make an impact on our cost of care spend?
So if I'm a startup founder, I'm out there listening right now, how do I get ahead of that? I know that, I'm hearing what you're saying, but how do I think about getting through the gatekeepers, partnering with the gatekeepers, or really just kind of getting past it so I can show my knowledge as a startup to try and make that sale? And I know that's a loaded question.
It's not a loaded question. I think oftentimes I would say, unfortunately, it happens too late. Because once you have a chance and an at-bat and an opportunity and you don't have kind of that work pre-prepared, it's almost like a wasted at-bat. The example I give to startup founders that I think would resonate would be, if you think you're at the 1 yard line, it's kind of like if you're going out to raise. You talk to a lot of investors, first meeting, you think, oh man, this is in the bag because every single investor is going to show excitement about, the opportunity, the pitch deck, etc. But the reality of the situation, if you start whittling down that funnel, the numbers get relatively small from a conversion rate perspective because there's this diligence process that happens. Similar, situation as it relates to health plan partnerships or payvider partnerships or RPE partnerships is that, you can demonstrate a great clinical concept. You can get the medical director on the other side or the CMO to agree that, yeah, we need a better clinical model for this particular set of populations or patients. But if you can't pass diligence and if you're not ready in terms of being prepared with that analysis to have that process go smoothly, you're going to be in for a long ride.
I want to set up a scenario for you here. I'm an early stage founder. I'm in a newer area. I've got a really intriguing clinical model. CMO loved it. Everyone thinks it could be a home run. How do I get ahead of diligence? What kind of information do you need to see? How do I prove something when I'm kind of looking at that first contract as the proof, right? We're probably going to put in the contract some risk, right? Where if we're not hitting metrics, it may impact us financially. So we're putting ourselves out there. But then how do we get past your group? How do we get there and actually show value when we don't necessarily have the value calculated? Can you give us some suggestions on what we can do?
It starts with being able to answer a few, what I think is relatively straightforward and reasonable questions. One, what is the clinical group you're looking to manage and change outcomes for? And the clinical group can be as specific as, a general population with a specific condition, or it could get very granular in terms of looking at a specific condition and a subpopulation that experienced a specific service or encounter within a population. And so you have to answer that question. Once you answer that question, the second question becomes, okay, great. Well, what is care as usual for me as a payer for the population of interest? What is the prevalence rate? And how do these patients go through the healthcare system and use medical services? And what is it costing me? Do you know the answer to that? And if the answer is no, you need to find the answer to that. Then the follow-up question becomes, based on your clinical model, what outcomes are you looking to change from a cost and utilization services perspective or health outcomes perspective? And what is the value of that relative to the answer that we just provided to me as a payer, that this is how much it costs you as usual? So really, it's those three components in sequential order. And then once we have validated that there is in fact an opportunity here, then it's like, what type of contract structure do we want to put around it to demonstrate that you have confidence in being able to deliver on that financial outcome?
So does the contract structure matter to you in medical economics? If a company is willing to put risk out there and take that on, does that make it more likely that you will find a comfort level with what's going on? Does that impact you in any way?
It doesn't impact, because for medical economics, we typically don't care as much about the contract structure as opposed to actually if there's a real opportunity at hand. Now, the request might be, hey, for this particular contract structure, is this contract structure realistic? Can it be achieved? That's a different question. But oftentimes what we're faced with is the question of, hey, if this clinical model going to do anything for us from a dollars and cents perspective, and if the answer is no, then it doesn't matter what contract structure you bring on, we're not going to have confidence that they're going to be able to achieve it.
Makes sense.
So that's kind of where my mind was going. Frank, Lon, and I, we've sold in our days quite a few risk contracts. So what happens when you've gotten through some of those initial steps that you've outlined, but all of the sudden you're looking to baseline something because it's a risk contract, but you have a variance of maybe it's 5-10%, somewhere in between there, but there's a variance and both sides feel pretty firm using maybe a set of data that startup company's analyzed, that they feel pretty good about their set, but the health plan feels pretty good about where they're at. How do you start to come to more of a middle ground there? And how do you start to, in some ways, negotiate that area?
And before you answer that, just because some early stage entrepreneurs may not fully understand, can you talk about what a baseline is just really briefly? And then we can get into the answer.
Yeah. So for risk or value-based care contracts, oftentimes in order to get reimbursed based on outcomes, you have to be measured against what those outcomes are. And in order to, determine if you performed well or didn't perform well, a baseline has to be established in terms of what is the kind of baseline/benchmark for which we're going to determine whether or not you performed well. Classic example would be emergency room visits or avoidable emergency room visits. We're going to look at either historical data or we're going to use kind of some type of benchmark to say, hey, like we're going to set this as what success looks like. If you can come under this metric, then you've done your job. If not, then you need to do better. So that's what a baseline or benchmark is. And it could not just involve utilization rates like emergency department, but could be cost of care benchmarks on a population. Anything that can be kind of measured against retrospectively would be considered the baseline.
Gotcha. And then Just's question was, what happens when you're 10% apart from the health plan? How do you begin to bridge that gap?
Yeah. So much of actuarial and medicon analytics in terms of how do you bridge that gap becomes I like to use this analogy as well because it's who has the best lawyers, right? It's like, how can you make the best argument and who's going to spend the most time digging into the data and producing the analysis to justify their case? Oftentimes, the provider or the digital health provider, the solution, they don't have any actuaries or medicon folks. So really, you really don't have anything to fight back against when the other side, you have a medicon person with a PhD oftentimes, or you have an actuary that's accredited, says, hey, this is the analysis. And really, what are you going to do to kind of push back against it? Which is why I think it's imperative if you want to have that conversation to be able to do really strong kind of pre-work on your end to be able to say, no, we've turned the data over a bunch of times. We looked at it the way you've looked at it, health actuary on the other side. And this is why the way you've done it is not correct, right? And so being able to make that argument and show with solid concrete data and analysis, that's what gets you to alignment.
Do you have to have an actuary on your team to be able to do that?
Not necessarily, no. It just so happens that the actuaries are like very familiar with this type of analysis,
right,
and have the kind of like prerequisite skill sets to be able to do it. But you don't have to be an actuary to really have to run this type of analysis.
So that's kind of where my mind went to. Some of these younger early stage startup companies, they may not have the team that can, 5, 6 actuaries on their team. Even 2 actuaries on a team is hard to come by, or none.
Or even one.
Early stage. Exactly. So what other resources are out there? If I'm, a startup company listening and I'm trying to land that first or even second health plan contract, are there companies that are recommended out there that I can go to try and get some of those resources, working with our team, of course?
And we'd love to hear more about Accorded. I mean, I believe that you do quite a bit in the space as well. So if you could talk about what's available out there and also a little bit about what you do, that'd be great.
I would say there are actuarial consulting firms that you can hire to kind of bring this capability in-house as a project, right? Like all of those questions that I had brought up, like you need to be able to answer those questions very clearly and succinctly, backed up by actual data. And those consulting firms can help you do that. So how does that relate to Accorded? Accorded is kind of similar in that we can also kind of support that, but we're really backed by technology. So we deliver in a way that is looking out for what comes next for early stage company when it comes to being able to successfully not just get these deals, but also how to operationalize them and build the internal operational capabilities that truly scale with an organization's need as they take on more risk over time.
So where do you get some of this data? Is there like a recognized data source that folks in the healthcare industry tend to lean towards, that you can get some of that really good just baseline data to work through?
Yeah, so you would license. There's available data sets out there on the market to license, both on the commercial side, CMS, you have to apply and go through this very rigorous process to kind of procure the data on the Medicare side as well as on the Medicaid side. And then there are companies that actually do the data aggregation from these various sources and kind of resell them as licenses to organizations that want them. The fees itself are relatively expensive for an early stage company, but I think the biggest problem is once they receive the data, even if they can get their hands on it, like what are they going to do with it? Like what type of kind of IT infrastructure that you need to use to be able to support an analyst or an actuary to actually run the data, assuming you can find the actuary and analyst who has the capability to produce the type of analysis. So it just becomes a very expensive, I would say, investment internally, not only just money, but also time that most of these early stage organizations really don't have. They have a deal sitting in front of them and they need to really be able to run this analysis as quickly as possible.
What's a cost-effective way to do this? If you're early stage, you may be seed, you may have just raised $500,000 or $1 million. You're barely paying yourself a salary, but you need to get over the hump and get that first contract. Is there an economical way to do it? Can you work with a company like Accorded that maybe has access to this data already and can help you with that, where you're not going and licensing data and then having to find an actuary to work with it? What are some options?
Most actuarial firms you talk to will have access to that data. So they can help support there. So you don't have to worry about the licensing fee. Most firms will have the expertise to be able to kind of run the analysis. Then it becomes, well, how much are they going to charge you, time and expense to be able to run it? And how many times is it going to take for them to be able to iterate? Because most of the times, these early stage companies, it'll be the first time they see kind of any type of cost of care analytics data on their business model. And so what that triggers oftentimes is interest in double clicking. Well, what about this patient population if I structure it this way? And so that's where it gets relatively expensive because really you're adding time and hours into kind of the process. So in the traditional consulting model, it can get pretty expensive pretty quickly. What differentiates, I guess, Accorded in that sense is that we can also help iterate, but we do it on a technology platform that allows us to do it in a order of magnitude more efficiently. So that savings is passed to our customers.
That's absolutely outstanding that there's something like they're out that. I'm sitting here thinking of my own startup experience. It says, Frank, where were you? Where were you all those years ago? I really could have utilized a service.
Sitting right here in my house in San Jose.
I don't know. You may have not existed as long ago as I'm referencing. But what are some other things that you can tell startup companies to think about during this process? Are there any red flags you think that everybody misses often that you want to notify them of? Or are there, just big steps that get missed? What advice can you give there?
Honestly, I think the biggest step is really kind of the advice I gave before. Like maybe, you can't answer the question right now, or you don't want to spend the money on a consulting service or even Accorded to be able to answer the question, prevalence rate, cost as usual, care as usual, care journey, what does it cost? How does my clinical model affect care outcomes and what is the business case? Figure out a way to scrounge the internet or do something, find studies, pull data. It's not going to be the best. It's not going to be great, but you have to have a clear answer to those sets of questions if you're going to truly get across the finish line with these deals and opportunities. Gone are the days when hey, we have a better clinical model. We have better member experience. We get access to care quicker. We're going to have a high NPS score. Yes, that's all great and wonderful, but we're in a different age where especially with 2025 looming and we have all of the CMS Medicare cost pressures going down, bearing down on these health plans where, making money on Medicare Advantage is not going to be as easy anymore, which means it's going to put pressure down through the entire system, starting from the MAPD plans down to the provider contracts, down to the enablers, down to, the vendors that are serving them. It becomes table stakes to be able to really put together a compelling cost of care value proposition in addition to, all of the other value propositions that these solutions offer.
And I'll just hit it. You mentioned Medicare. So a couple of those pressures that Frank is speaking to would be risk adjustment changes that have come into play, a reduction in the annual increase in premium, utilization rebounding back to post-COVID or getting closer to where it was COVID time. So there are a lot of pressures that are on health plans. So you really have to figure out how you're going to be able to address that. Hey, one thing that comes to mind, because Jess and I have dealt with this, is the COVID issue on baselines, is that over? Or is that still an issue? I mean, it's been, 4 years? Is that still an issue?
If you look at the trend line for the data that we've seen, the trend line is pretty consistent, save for a dip in late 2020 to 2021. So what you would see is, again, in the models that we've analyzed, you see this trend that would go this way. I don't know how this looks on your screen, but you have a trend that goes this way. There's a little dip.
Going left or lower left to upper right.
There's a little dip for COVID. And then if COVID had not existed, it would just be that trend line going exactly this way. And maybe it's not as steep, but maybe it's a little bit like this. But I would say that if you're baselining in any period of time outside of that COVID dip, you should be fine. This is kind of we've seen it stabilize.
So is it back to pre-COVID levels or is it? It is.
It
okay,
is.
Good to know. I wasn't sure if we were there yet. Mm-hmm. So thanks. That's very helpful.
Mm-hmm.
Frank, you kind of sit the epicenter of looking at all of this data and these trends. And when you work with different companies, where do you think our industry is moving? What feels kind of on trend right now, especially with what Lon just talked about with some of the pressures that MAPD plans are facing right now? What feels most relevant for health plans and for maybe VBC providers today?
So much of VBC has been centered around, for the last 2 decades now, primary care. For good reason, right? Primary care, we know it could be better. There's just so much opportunity for primary care to be run in a way that really kind of drives and touches on outcomes. But at the end of the day, 70% of medical spend is not touched by primary care influenceable activity, meaning that that 70% is coming from specialty care. And so what I see as kind of the next frontier of value-based care, given that I feel like we've, squeezed all the juice out of what primary care can do, is to figure out what kind of the next frontier of value-based care is as it relates to specialty, where that's where you have like 70% of the cost. And yet we still, up until today, have been very much focused on primary care. That's changing. We've seen CMS models coming out with more programs around specialty care. We have these private health plans that are looking at specialty care, moving those contracts to risk. And I think that presents a lot of challenges in that when you start thinking about specialty care, you're reducing end size, but yet increasing variability. And so how are it's going to be hard to figure out some type of like broad-based, consistent, monolithic payment model. It's really going to have to be priced and contract on a case-by-case basis, looking at the data, interrogating the data. That's where the next frontier is. Now, we'll see how quickly we move, but that's where there's a lot of opportunity.
We just recorded a great episode on one of those models, so we'll save that for a later point. Jess, do you want to jump in and ask about reconciliation?
Yeah. So Frank, this is getting a little bit of ahead where we've talked about, but these startups, they get into arrangements, they've landed what you've talked about. They've gotten through the contracting, they've inked the contract, their program's live. Can you talk to us a little bit about how companies should be prepared during reconciliation if it's a risk contract? What can companies do to ensure that is a successful, meaningful conversation that does not go sideways on them? And all of us are smiling. For all the listeners.
And for those that aren't watching this and are listening, Frank's eyes just blew up when we asked that question. I think it's a big question. So,
I think that the reconciliation question is addressed too late. Things happen too late when it comes to getting into risk contracts and getting into value-based care contracts. When you ink your deal, that should be the time when you're thinking about, okay, I inked a deal. We're going to go live. Like, you should be thinking about your operational and analytical processes to ensure proper reconciliation right away as your next step. And the reason being is because there's so much that happens during reconciliation and so much is in flux that if you can set up the proper analytical pipes to be able to track and monitor how you're performing against those key performance metrics within the contract, then you're set up to really drive the narrative with the payer during reconciliation and renewals to ensure that you have the reins of the narrative. You can talk about like whether or not like these metrics were achieved. And even if you didn't hit those metrics, oftentimes I'll say, hey, it's like 90% of the time, it's like out of your control. You didn't hit the metrics, not because you like somehow drove, your engagement model is not going to drive up more emergency department utilization, right? So what's the answer to why that happened? Well, that's if you have the proper kind of analytical framework and operational framework to be able to answer that question and say, hey, like we didn't hit this metrics, but it's not because we didn't do a good job. It's because we had a different case mix of patients relative to what we established as the baseline, right? That's a very reasonable explanation. If you have the analytical proof to say, this is how we've analyzed it, here's how we looked at it, that turns into a very different renewal and reconciliation conversation than if you were to just like, well, you're telling us we didn't hit benchmark. What do we do now? Right? And so again, I think it's a lot of just proper prior planning and anticipation of what's going to happen and being strategic about how you set up your own internal processes and infrastructures to meet the demands that you know is going to come during that time.
That's a great point. And the other thing is if you set up the pipes and the process early, you're able to catch issues and course correct quickly and not wait until reconciliation to do that, right? So it gives you a lot of opportunity to get things on the right track if you don't.
Yeah, that's exactly it.
Very, very helpful. Hey, Jess, do you have any other questions before we wrap this episode? It's been great.
Frank, this has been so helpful. This is going to be one of those ones that I feel like even I need to go back and listen to on repeat.
I completely agree. Frank, you have been fantastic. Really want to thank you for joining us. Frank, what's the best way for people to get in touch with you and learn about Accorded?
Yeah, if you want to learn about Accorded, feel free to hop onto our website, accorded.com. If you want to reach out to us directly, learn more about what we do and how we help organizations really succeed in going out to market and actually operationalizing and growing their value-based care contract model in business, shoot us an email, learn@accorded.com.
Thank you so much, Frank. We're going to wrap up another great episode. Really appreciate your time. For more advanced content, go to healthcaregrind.com and please subscribe on your favorite podcast network. So thank you so much. Frank, it was great having you on again.
Lon and Jess, thank you so much for having me. It was a great conversation.
Thanks.
As we wrap up this episode of the Healthcare Grind, we want to thank you, our incredible audience, for tuning in. If you found today's insights valuable, don't forget to hit subscribe and leave a review on your preferred podcast platform. Your feedback fuels our grind. For more exclusive content and updates, visit our website, healthcaregrind.com. Until next time, keep grinding, stay informed, and lead the charge in shaping the future of healthcare. This is Jess and Lon signing off from the Healthcare Grind.